Now we're going to go into something much closer to what reality is and what we want to see about coronary artery disease and plaque and stenosis and all these things that make imaging interesting. To prepare such a talk, it was quite easy because in 2020 there was this expert consensus document issued by the Society of Cardiac CT that says everything about the plaque, all the studies, everything. So you can, instead of listening to me, you can study this paper. It has everything that you want to, you need to know about all the recent developments. But I isolated this sentence that says that atherosclerosis, we have to keep this in mind, that what we're dealing with is not stenosis, it's atherosclerosis. And atherosclerosis is a primary disease process that mediates risk and outcome and stenosis. Stenosis is only one of these many subsets. So it is stenosis, it's a vulnerable plaque, it is the inflammation, but it's not only stenosis as we knew up until now. I would like to draw your attention on this paper issued in 2018. It is a very interesting meta-analysis and follow-up of the COFIRM registry patients. And in this, they retrospectively studied the CT angiograms of patients that had, after they had an angiogram, they had a major adverse cardiovascular event, so myocardial infarction or angina. And in this very interesting study, it was demonstrated what we all knew but we could not demonstrate from before, that out of the 129 culprit lesions precursors identified on coronary CTA retrospectively, the stenosis was in 75% of the cases was less than 50%. So it's not the stenosis that causes the events, it is the plaque that causes the events. And now we should start straight from the beginning and try to utilize these nice images that Dr. Theophilakis showed us before on the evolution of the atheroma plaque, which is a normal process if it occurs at the normal age, depending on the sex. And so it is not always a disease. If we look at it a little bit more radiologically in 3 dimensions and make a cross-section of the wall, of the arterial wall, we will see that at the beginning, as from a normal artery to go to the early atheroma, usually there is no stenosis. Of course, this occurs with some positive, some negative remodeling too, but here at this stage, we can see that the wall, the lumen is unaffected. And then it can proceed to different, depending on how bad the risk factors are or what is the situation of the patient. It can proceed to a more chronic stage that does not really affect the lumen and the wall, and it's mostly fibrous. The consistency of the plaque is mostly fibrous. Otherwise, it can proceed to a worse plaque that is ready to explode. You can imagine how the tension is on this side of the wall, since the wall has, I don't know, increased its size by 20 times. So you can understand that there is a lot of tension there. And we have to make this comment because all this time we were talking about calcium plaques and talking about hard plaques or soft plaques. This is not the situation. Calcium is not hard. And of course, a non-calcified plaque can be hard, but depends on the consistency. It's not always hard. It can be very soft plaque and might not have any hematologic potential. And then we see here that when this thing happens, because of the tension, the accumulation of ingredients, we'll have the leakage and break a gap in the intima, and then a hemorrhage, thrombus formation, and myocardial infarction or embolism. What is really important to know is that until a vessel has reached this point that can be fibrous or calcified, or even without such a great remodeling and stenosis, all these stages are quite dynamic. I mean, a plaque that is towards stability at some point can regress to instability, depending on how bad the risk factors affect the patient. And what Alex showed before about the ischemic cascade in comparison to the flow diameter, to the vessel diameter reduction, and how this thing goes on to proceed to myocardial infarction. Although we're radiologists, we have to start thinking about the patient. And it's not the images that we're actually looking at, it's a patient. So, and we have to categorize our patients and our studies as asymptomatic individuals who are examinees, and symptomatic, which they can potentially be patients too. So like a person like this who is asymptomatic has a profile of a person who wants to live healthy and to work out and be fit. On the other hand, you have this guy that has a lot of bad habits, might have subclinical disease or not, but he doesn't have symptoms because usually does not do too much. So, I mean, that no matter if there is a stenosis or not, the blood is enough to go from the car back to the pub. And then you have symptomatic people that can be experiencing an acute event like in this situation, or symptomatic people that are in chronic stages, either having chronic angina, so they have struggle in doing some effort to work like in this situation, climbing up the stairs, or it can be, this can be also seen in patients with heart failure. And these are the different stages of coronary artery disease. And trying to see coronary artery disease and the plaque, everything started in 1927 when they firstly did some type of coronary artery imaging, but it was, as Strato said, Andreas Grunzig, that he performed the first PCI on human in 1977, the year I was born. And of course, we can see here that, sorry for this, I'm trying to play the video. Anyway, we can see here that the catheter angiography, we can see the stenosis here in this video. We could see how we could open the lumen again. Of course, interventional coronary angiography does not see the plaque. The method that was developed, intravascular methods developed to see the plaque, they're really very good. They're very good to characterize the composition of the plaque. So we have IVUS, intravascular ultrasound, with virtual histology, or with endovascular elastography or optical coherence tomography. These methods are the gold standards to see the quality of the plaque. However, they're interventional. They can see vessels up to 2 millimeters in wall, whereas plaques occur even in smaller vessels. And of course, you understand that it's going to be very hard to see all the vessel length with an ultrasound, and it's going to take a lot of time. So, but this is what is the basis to how we see, we look at the plaque, all the knowledge produced by these methods. And here we can see that in this virtual histology technique, we can see what is fibrous area, what's fibrofatty, and dense calcium. And what is really, or like in this area that elastography sees the density and how hard the tissue is. And here we have OCT that is the excellent to detect the very thin fibrous cap, which is the hallmark of a vulnerable plaque. But all these things are interventional, and they're very, very high cost because all the catheters, and it is not very friendly to the patient and even the person who performs them. What is really interesting to see that there are a lot of studies that have done that showed that CT shows exactly the same as intravascular ultrasound, pretty much. So right now we have all the knowledge that we need that we can characterize a plaque on a CT scanner, because we have the validation that CT sees the same thing as intravascular ultrasound. And this is a vulnerable plaque. This is quite a typical vulnerable plaque. It's a histology. I think it's better to imagine it like this because it gives a better representation. Here we have the large necrotic core, and we have the lumen. And in between here, there is a fibrous cap. That is, when it is really thin, less than 65 micrometers, then it is very easy to break and to have a hemorrhage and an acute cardiovascular event. Also, hallmarks of vulnerable plaque is the neovascularization, so proliferation of vessels, and the necrotic core, which is mostly fibrous and contains debris of the macrophage production. These excellent papers published in previous years in 2017 and 2015 and 2018 by the group of Budapest, Polmarovic, Horvath, and they show very nicely that CT can depict and describe correctly the composition of the plaques. They also state in these papers that the CT coronary angiography is the only non-invasive imaging modality for the evaluation of non-obstructive CAD. Even interventional coronary angiography cannot see a lesion that causes 10%, 5% luminal diameter reduction, because it's a two-dimensional technique. And demonstrating these plaques can change the contribute to change the events, so decrease the number of adverse cardiovascular events. So that we also have demonstrated, recent studies has demonstrated that vulnerable plaque, unstable plaque features have worse prognostic value over stenosis. So it's better to have a significant stenosis than a vulnerable plaque. And up until now, we knew that stenosis was the issue. And there is discordance between the degree of stenosis and ischemia, because there are a lot of different parameters, like the quality of the vessel, so the vessel's compliance, and also some things like if the territory receives vascularization from retrograde. And so stenosis and ischemia is not the same. And plaque morphology assessment is as important as stenosis assessment. So trying to characterize and describe a plaque, we can talk about the composition and the morphology of the plaque. Composition, up until now, we knew the calcified, partially calcified, and non-calcified plaques. Now we have a new category, which is the low-density non-calcified plaques. Calcified plaques are plaques that have attenuation more than 150 Housefield. Partially calcified is anywhere between 60. These numbers, they are not very reproducible, so different vendors have used different numbers, and of course all other things that change the composition, like techniques. Partially calcified, so this is calcified plaques, and then partially calcified is that they have mostly non-calcified or mostly calcified, but they have both constituents. Non-calcified are fresh plaques, and the low-density non-calcified plaques are plaques that have a constituent that is less than 30 Hounsfield unit. It's almost fat. Now, morphology, you have stable plaques, unstable plaques, and vulnerable plaques. And as I told you before, all this is a dynamic condition. Let's start with calcified plaques. We can see here that all in this patient, all vessels have quite diffuse calcified plaques. We know that what we see as calcium is a little bit less in reality, because there is always blooming with some calcium. And you can see that although that there is a lot of calcium, the lumen is pretty much unaffected. Maybe this patient, if he had a interventional coronary angiography, they would describe minimal disease. But we can see here that there is a lot of disease. And the same thing we can see here, these nice oval-shaped plaques that cause only minimal or even milder stenosis. At some point, they even coalesce along on both sides of the lumen, but they do not cause any significant stenosis. And this is a typical benign plaque of like oval-shaped that does not cause any luminal stenosis. My teacher, Dr. Tarun Mittal, was always saying that if you see a calcified plaque, don't think that there is critical stenosis. If you see a calcified plaque and some lumen, even though if it seems that most of the lumen is affected, it is non-critical. We have partially calcified plaques here that might cause mild stenosis or critical stenosis in this situation, or both of them can coexist on the same patient in the same vessel segment. Who say that coronary CT is a snapshot in time. Things change. They're not because you had a non-stenotic lesion in the past. That doesn't mean that in the future it's going to stay like this. Plaques change. And or here we can see some plaques with spotty calcification that have non-calcified part. And here we have the typical napkin ring sign appearance of a partially calcified plaque. Now, non-calcified plaques can exist alone, so we know that there is a lot of patients that they had a calcium score of 0 and they have significant stenosis, or they can exist along with calcified plaques. We have to remember that calcification or non-calcification pretty much means the time of the life of the plaque. At some point it will be non-calcified, later on it's going to calcify, and then in the end it's going to become fully calcified and fully stable and hemodynamically insignificant if everything goes well. If something goes wrong in the meantime, you can see a lot of different scenarios. And we have the low density non-calcified plaques that you can see here with the plaque analysis tool. You can even see it with the bare eyes here that there are some areas that are really low attenuation. And these are the typical vulnerable plaques. And in this paper that is based on a meta-analysis of the Scott Hart trial, they say that low attenuation non-calcified plaque burden that is more than 4% in a specific plaque, not overall, but in a specific segment of the vessel, it is much worse than having two vessel obstructive disease. It has a very bad outcome in regards to MACE. Just the fact that one plaque might have 4% of these low intensity constituents. And this is from a very significant study for the Scott Hart. Then we have now trying to characterize their morphology. We have stable plaques that we can see here. Even in this situation that you can see them across both sides of the lumen and the sandwich the lumen. This is not the reality. We'll have to change the window. You can see that finally the lumen is much better than this. Of course there is a stenosis here, but it's non-critical. And here you can see a plaque that this is the remodeling that you expect if everything goes well. Something like this, an oval-shaped plaque that barely produces any stenosis. Unstable plaque is a plaque that has some unstable features. So like in this case, there is, it's partially calcified. However, there is only one unstable feature. So in this case, we might have of course, in case it is a napkin ring sign, it is enough to call it vulnerable. However, here, this thing, if there is only one feature, we can call it unstable. And as I told you before, it can regress to vulnerable, or progress to vulnerable, or regress to a very steady situation and chronic stenosis. So, vulnerable plaques have low attenuation. They have high positive remodeling index, so the remodeling index, it is more than 1.1. And if this remodeling is homogeneous, the positive remodeling, I remind you, is remodeling of the vessel wall that does not produce stenosis. So if it is homogeneous, it's quite stable, but heterogeneous positive remodeling is a sign of instability. And then we have the napkin ring sign plaques and the non-napkin ring sign plaques. And the ones that are napkin ring sign, they have spotty calcifications. This is the hallmark that the non-napkin ring sign plaques. So there are four different type of vulnerable plaques. Here I have to stress that regarding the attenuation, it has to do a lot of things changed according to the technique. So if you acquire very thin slices or depending on the tube voltage or the contrast that you achieve, things might change. They are not so reproducible, the attenuation of characteristic of the plaques. And this schema in the paper by Paul Morovitz Horvath in Nature, you can see here histology and coronary CT and how well they correlate on the abnormal areas. And it's very nicely see here that in the same person, in the same vessel, you have all different type of plaques. So we have non-calcified, this is the traditional calcification. This term has been abandoned. There is no mixed plaque, it's called partially calcified. And here you can see the positive remodeling, a heterogeneous positive remodeling, homogeneous positive remodeling, which is mild unstable, heterogeneous, which is significantly unstable, and the napkin ring sign, which is calcification, thrombus, and lumen, one after the other. And here in this diagram, the spotty calcifications, we have to say that calcifications that are less than 3 millimeters in diameter, in maximum diameter. Then you have this typical appearance, the napkin ring sign, which is, I don't like this term, however, we have to use it. And the low attenuation plaques and the positive remodeling if the remodeling index is more than 1.1. So here I will show you some relative plaques of its different type. Here we have some minimal stenosis, Cadrads 1V cases, so that they have the plaques, they have vulnerable characteristics like here, napkin ring sign, spotty calcification with extensive positive remodeling, and here a very spotty calcification is a little unstable. Here things get worse. Again, vulnerable plaques, but here they produce significant stenosis. Before it was Cadrads 1V, so minimal stenosis with a vulnerable plaque. Here we can see significant stenosis, almost occlusion, and you can imagine how bad this situation here. I mean, all this plaque has the napkin ring sign, the lumen is only left in this spot, and of course the patient has to be symptomatic. And vulnerable plaque, we can discriminate vulnerable from unstable. A vulnerable has two unstable characteristics. If it has only one unstable characteristic, we can call it unstable. And if they have if you have a T-feature positive plaque, and so like it has a low attenuation part and positive remodeling, this patient will have a 22% of having an acute cardiovascular event in the next 2 years. And of course, the events, sometimes they happen because of enlargement of the plaque, but this is very rare. Adverse cardiovascular events happen when the plaque ruptures. So if it is a plaque that slowly grows and eventually diminishes the lumen, then we'll have enough time to get new vascularization and not have ischemia. And the high-risk plaque characteristics are as very good and correlate with invasive measured FFR. That means that the FFR has shown that if the plaque is more vulnerable, creates more significant hemodynamic compromise. It's not only the diameter, it is the consistency of the plaque that makes the hemodynamic compromise. And of course, we're really good with this because there are drugs that we can change the situation. So statins or some anti-inflammatory drugs can have been shown to change the fate of a vulnerable plaque. Who have to report for all plaques, all these different things, and of course report the stenosis. And in the past, we used to use these tables to grade the stenosis. In the guidelines of chronic coronary artery disease, it was mentioned that it is not 50 or 70%, it's 50 to 90% that we cannot predict the hemodynamic importance of a plaque. So we need the functional tests. In the case if we have a diameter stenosis of 50 to 90%, then we need the functional test. And unless we have a very high, more than 90% stenosis, then we will need interventional coronary angiography. This is the scheme that Alexandros very nicely showed and I think drew your attention, but I want to also show you this one, that finally, even coronary angiography, interventional coronary angiography cannot describe the diameter of stenosis correctly, and this has to do with the length and the inherent characteristics of contrast flow. So you would always, probably all of us say that here is subtotal stenosis, subtotal occlusion. It's only 83% diameter reduction. So there are a lot of things to see stenosis and plaque. And as Alex said, it has to do with the remodeling. And right now, the gold standard of stenosis in the past was FFR, and as both Alex and Ilya said, that coronary flow reserve produced by stress MRI or stress CT or PET is as good as interventional FFR. And there are some new biomarkers like segment involvement score that can predict the risk more than the plaque features. There are some other biomarkers like the segment involvement score and some other scores, the CT-Lehman score 21, that can they have very big role in predicting future events. And patients with non-obstructive valve involving more than 4 segments, they have the same risk as those who have obstructive CAD, more than 70% stenosis. So it's not the stenosis, it's the plaque. And from the first paper that I show you about the plaque morphology, what they suggest is this, that we start characterizing our patient, stratify our patient in this pyramid depending on the plaque characteristics produced by the CTCA. So we'll have stratification, risk stratification depending on calcium score, and risk stratification based on CTI coronary angiography. Thank you very much.
Thank you, Kostas. Fantastic approach. You show us so many important features of the atherosclerotic plaque that can lead to an adverse event. And I don't know if we have some questions from the audience. Ask, yes, I would like only to ask Kostas about the cartridge system that you mentioned. Are you using this? Do you suggest to use this classification in order to have a common language with the referral physicians?
Of course, I think you cannot utilize coronary CT angiography without producing, if you don't produce a clinical useful report, and of course cartridge is the cornerstone to that. I think you cannot report coronary CT angiography if you do not mention in the end the cartridge. It's the same thing as doing mammography without BRADs. So I use it, however we expect a new issue of cartridge. We know that there are a lot of drawbacks in the cartridge as it is, because it is mostly focused on the stenosis. And we know it's not only the stenosis. Of course, in the cartridge we have the discriminators, vulnerable, stent, graft, or non-diagnostic, but I do not think there are a lot. I think we need more discriminators like anatomic anomaly, like myocardial bridge, maybe not myocardial bridge, but some coronary anomaly, some other anomalies, or of course more characterization of plaque stability. And we expect the new cartridge to include all these new issues, to address them more, to describe all the information included in the CT coronary angiography.
Many thanks.
Thank you.
Okay. Thank you, Kostas. Thank you very much. And let's continue with Dr. Alexandros Kalifatidis. Dr. Kalifatidis will answer about if CMR is a one-stop shop examination concerning the coronary artery disease. It's a very good question, and I think we'll have a lot of interesting topics in this presentation. Thank you, Alexandros. Your
Thank you very much.
Is for you.
Thank you very much, Thanos. And we will see if CMR can include all in one. Before Kostas mentioned probably CT could be the one-stop technique, but let's see what we can see with CMR. And just to remind that heart disease remains the first cause of death in the West world, coronary artery disease has a major role in the morbidity and mortality worldwide. And it was impressive a few years ago when I read this article that mentioned that nearly 80% of heart attacks in the United States are never diagnosed. So it seems that there is a problem in the diagnosis, and of course we have to take account, as Stratos mentioned in his presentation, we have to count in the information from the history, the clinical examination, ECG, the biomarkers like troponin, of course, a major role of troponin, and we have in addition imaging techniques. From the imaging techniques Kostas showed before, we can proceed with catheterization. Of course, it is an invasive technique. It is considered the gold standard. But this shows that approximately 55% of coronarographies are only for diagnostic reasons. We don't have a further procedure. We don't see any obstructive coronary lesions, so we stay in the diagnosis. So it will be preferable to have non-invasive techniques in order to see this and assess our patients. Of course, during the invasive procedure, we can perform invasive FFR, IVUS, OCT. These are procedures that increase the risk and, of course, the cost. What about the non-invasive techniques? We have in our arsenal several imaging techniques. Of course, echocardiography is the primary investigation tool, but we can use SPECT, cardiac CT, PET, with less availability, of course. And let's see what about cardiac MRI. And why cardiac MRI? Because It is a fantastic imaging technique with a lot of advantages. It is non-invasive, provides images with high diagnostic quality. We can scan the heart in multiple planes with no acoustic window limitation. And the main advantage is the tissue characterization, also with modern techniques and mapping. And here we can have an overview of all the sequences that we can use in order to assess the anatomy, the function, the global and regional. We can see the adaptation and the remodeling of the ventricles. We can calculate the flow. We can see edema, perfusion defects, late enhancement, and we can even calculate strain values and other techniques in order to quantify flow with 4D flow. And as I mentioned in my first presentation, there are already standardized protocols. You can search this publication, nicely describes how we can use and how we can interpret afterwards the images also in the field of coronary artery disease. That's why this technique all these years has expanded. There was a huge increase in the indications of CMR also for coronary artery disease and chest pain syndromes. We can see this also from this registry, the registry from the European Society of Cardiovascular Radiology, in which Greece and our departments participate in, and we can see this increase in the number of submissions in cardiac CT and cardiac MRI, and an important percentage is about suspected or known coronary artery disease. According to the guidelines, CMR is increasingly used in order to diagnose coronary artery disease and in order to detect and assess CAD, in order to show the hemodynamic relevance of a coronary stenosis and give us prognostic information, thus to guide the therapy. And very lately, we have this recommendation from SCMR and all these important societies, and show us that in different clinical scenarios for acute and stable chest pain, we can use CMR for our diagnostic dilemma. So we can use CMR in non-acute, more chronic, and as well in acute phase. In non-acute, we can assess function, we can make stress techniques. We will see if we can make a MR coronarography, newer techniques like mapping, late enhancement, etc., etc. In acute phase, we will search for edema. We will use MAP and, of course, late enhancement, the function, and we want to make the differential diagnosis from other acute syndromes. CMR, just to remind that it is the gold standard imaging technique for the assessment of biventricular volume and mass and the injection fraction. It is a technique that we can not only estimate the global function, but we can see as well the segmental function or dysfunction. Here is an example, the first video here, a normal case with no abnormal wall motion movement. On the other hand, here we have a hypokinesia in the lateral wall. That was the case with myocarditis. On the other hand, here we have a thinning and akinesia in the lateral wall. That was the case with infarction in the lateral wall in the circumflex territory. We can even use strain techniques in order to see this dysfunction with color maps, but also we can calculate the strain values. Here is a case with an infarction in LAD territory, and we can see these abnormal color values in the anterior wall and in the apex, and also we can calculate the abnormal strain values. Also, we can measure the myocardial thickness in any segment, in any projection with no acoustic window limitation. We can see we have a thinning or a myocardial hypertrophy, or if it is normal. Why stress? Of course, we analyzed this, all this in the first session. Just once again to remind that as we have seen, stenosis is not always ischemia, and especially in moderate coronary artery disease, additional information required. We have the stress test techniques in many clinical scenarios. We can use vasodilators like adenosine or regadenoson. Once again, the perfusion sequence in order to see the ischemia. According to the territories, we can estimate the responsible vessel. And here comes the second quiz, a clinical case, and I ask you to carefully see this case. This one in the first video, the first pass perfusion during stress, and I want to see if, to check if you see any perfusion abnormality, and here it is in the same position, the rest perfusion. And after seeing carefully this, let's vote, and please vote if there is any perfusion abnormality, and if yes, in which territory is the relevant stenosis. LAD territory, we have a normal myocardial perfusion. It is in the circumflex territory, RCA, or in LAD plus circumflex territory. Okay, and let's see the right answer. In this case, it is the right coronary artery territory, and this patient with this positive stress perfusion CMR examination, he referred for further catheterization. Here we can see from the catheterization the multiple severe stenosis in the right coronary artery, and after the angioplasty we can see the nice result, and now after the angioplasty, right coronary artery has no significant stenosis. And once again, to remind that we have to display the stress, the rest, and the late enhancement images in order to see if there is an inducible ischemia. Here we can see the during stress, this hypoperfusion defect, that it is normalized during stress, no disappears during rest, and we don't see any enhancement. So this is a case with inducible ischemia. Let's see another clinical case. It was about a veteran athlete, basketball player, asymptomatic, that he had a coronary artery computed tomography as a screen that showed a probable severe stenosis in the ostium of LAD. So this patient referred for further exploration to the cardiologist and the catheterization, and we can see this stenotic lesion in the ostium of LAD that it was quite tricky, probably is not so severe. The cardiologist wanted to be sure, and they proceeded with invasive FFR that showed normal values, more than 0.8, it is considered a normal FFR values. So it was not relevant, this stenosis. This patient had medical therapy, and after 6 months, as a follow-up, we performed a stress MRI. Here, the first scene sequences in 4-chamber view, normal biventricular function, also the T1 mapping here in grayscale, normal values. We proceeded with stress MRI, but during stress we don't see any perfusion abnormality. Maybe we can see this dark cream artifact in the septum, in the mid slice, but no true perfusion defect. So a normal study. Also no delayed enhancement, and with post-T1 mapping we calculated the ECV that was also the extracellular volume that was also normal. Other techniques that we can use, Ilias mentioned before, the dobutamine, and we can have protocols with low dose and high dose. Here is a case that during the low dose phase we don't see any abnormal contraction, but during the high dose as you will see here in the lateral wall, there is a delay in the contraction, and this patient had significant stenosis in circumflex artery. What about MR coronarography? We can assess coronary arteries with MRI. This is a non-contrast technique, whole heart, and we can see that we can cover the heart like cardiac CT, of course not in few seconds, but in 5 to 6 minutes. Afterwards, we can have projections like cardiac CT, but according to the guidelines, coronary MR is only indicated when we have a question about if there is any anomaly in coronary anomaly, or if there is any coronary ectasia or aneurysm, especially in children. For example, if there is any Kawasaki disease, we can use CMR with no radiation exposure and non-contrast, and we can assess the coronary arteries. But there is a lot progress and technological improvement also in this field. We can see these excellent images and correlation with CT, nice projections of the coronary arteries with MRI. We can see the stenotic lesions, or we can see different sequences in order to see the characteristic of the plaque and if it is more unstable and vulnerable. Other technical innovations, here examples from this excellent publication. We can see the stenosis, we can see the plaque morphology, the correlation with coronarography, techniques that we can use in order to improve the diagnostic quality, free running coronary MR angiography, or here with motion correction. And here whole heart non-contrast in combination with bright blood and black blood appearance, so in order to better see not only the lumen but also the plaque, and fusion images in order to see the activity, the plaque activity in combination with CMR. But despite this impressive progress, still, these sequences are used only for academic reasons. We are still facing important technical difficulties. Of course, cardiac CT is uncompatible in this field. We can scan the coronaries with CT even in one heartbeat. But it is a very promising technique. And there is a need of multi-center clinical validation, of course, and prognosis trials comparable with cardiac CT in order to see the advantage of this technique. What about in acute phase or in patients with heart failure or post-PCI and CABGs? We can use CMR once again for the global and regional functional assessment in order to see if there is any edema and the area, the peri-infarct area at risk. We can see the extension of an infarction after an acute event. We can see the viability of the myocardium. We can search for any complications like ventricular thrombus or microvascular obstruction, and we can add in specific clinical scenarios stress CMR. And of course, we can differentiate from other acute coronary syndromes. Here are some clinical examples from the literature. We can see, we can see an extensive infarction in LAD territory, here in this area with the associated edema. In the other case here, much more extensive. We can see all this area, the infarcted zone, and inside this area, this dark zone, I will explain later on in what a pathophysiologic feature corresponds this dark area, but we can see also the edema and also this dark area here inside the edema that corresponds to hemorrhage inside the infarcted area. And with late enhancement, we can see the extent of the infarction. We can make the differential diagnosis. Don't forget that infarction always starts from the subendocardial area. If we have an affection in the subendocardial area, or it is transmural, we have a case of infarction. Other types of late enhancement, other patterns we can see in other pathologies, and we can make the discrimination. Here we have an example, two dysfunctional, severely dysfunctional left ventricles, this case here, another case here, but with completely different pattern of enhancement. That was a case with an extensive infarction in LAD territory, with thinning and dyskinesia of the anterior wall and of the septum. On the other hand, here is a patient with dilated cardiomyopathy, and we can see this mid-wall stripe of enhancement, pathognomonic and bad prognostic sign for these patients. Or we can see two different types of enhancement. Here in a dilated left ventricle, we can see also this mid-wall pattern, but in addition, we can see this infarcted area in the lateral wall. And this technique, late enhancement, it has been shown to be the gold standard in order to assess even small infarcted areas that with SPECT could not be easily seen. And Ilias talked before about viability, actually, and I will just would like to mention that if we have a transmurality of up to 50%, then we are dealing with a viable myocardium practically. If we have more than 75% transmurality of the infarction, we are speaking for a non-viable myocardium. And in between there is a gray zone that maybe we can add a low dose protocol of dobutamine to see if we have an improvement in the movement of the myocardium. Here an example with a small infarcted area in a patient, diabetic patient, 50 years old, a silent infarction here, so very important information from CMR. And here we see another patient with extensive infarction in LAD territory, severe dysfunction of left ventricle, and the thinning of the myocardium, especially in the anterior wall and the septum. And it is important to know why it is important to know the infarct size, because it correlates with worse prognosis. And if we have patients where there is a contraindication for the contrast, for example, patients with renal failure, we can add techniques, non-contrast, like T1 mapping, newer techniques, and here we have a case with this subendocardial infarction. This is a non-contrast technique, and this is another tool with CMR in order to assess coronary artery disease. You can search this excellent publication showing the different patterns of late enhancement and how we can use T1 mapping and ECV in order to differentiate cardiac pathologies, and we can even differentiate acute from chronic myocardial infarction. In addition, we can see and search for infarct complications. Here it is a case with an infarction in LAD territory, a thinning of the apex, and this formation here, it is this is a thrombus formation after the infarction. We can see it also with T1 mapping techniques and after contrast that doesn't have any contrast uptake. So very important information that can easily missed with echo in this area of left ventricle. Other complications, this is a patient with late referral for catheterization. So we can see this dysfunctional left ventricle, especially in the anterior wall and in the apex. We can see also this quite important pericardial effusion, and with late enhancement, we can see the extensive infarcted zone. This dark area here that I told you before corresponds to microvascular obstruction, and it is this correlates with a bad prognosis and worse prognosis in correlation for remodeling in comparison with infarct extension. Other complication here, huge pseudo aneurysmas here in the apex of the left ventricle and here in the posterior inferior wall with thrombus formation. We have also the pericardial layer inflammation and enhancement. We can see once again the thrombus inside the pseudoaneurysm, and also we can assess this pathology with mapping techniques. We can differentiate from other acute situations. Here once again typical infarction affecting the subendocardial area. Here another acute case with subepicardial enhancement. That was a case of myocarditis. So very useful technique in order to make the differential diagnosis. You can check this latest updated Lake Lewis criteria of how we can use this technique for patients with myocarditis. Also we can assess edema, very characteristic once again in the epicardial, subepicardial area, and patchy formation. This is a case with myocarditis. Other clinical pathologies, we can make the differential diagnosis from Takotsubo cardiomyopathy, which is a stress-induced cardiomyopathy, especially in post-menopause women, a broken heart syndrome, and here is a clinical example. We can see this apical ballooning of the left ventricle, also the dysfunction in short axis slice, but with no visible enhancement. And we have to mention that this pathology usually is reversible, and if we will examine our patient 1 month later, maybe we will not see any abnormality. And here another clinical case, 52 years old female that presented with chest pain to the cardiology department with troponin elevation, and she referred for further exploration with coronarography that showed no obstructive lesion. So after this, the patient referred for cardiac MRI in order to see what was the mechanism that led to this pathology. And here we can see that in general we have a preserved global injection fraction. We see here a thinning and a dysfunction in the lateral wall of the left ventricle associated with edema in this area, as we can see here with the STEER sequences, and with mapping, T2 mapping, in order to assess edema. Also we can see the abnormal colors and we can measure the abnormal values also with T1 mapping. And with post-T1 mapping, we can see this area. This was an infarcted area, and that was a Minoka syndrome. Just a few things about Minoka syndrome. Refers to a group of myocardial patients with no angiographic obstructive coronary artery disease in a major epicardial vessel, and indicates that there is an ischemic mechanism responsible for the myocyte injury. The prevalence, it is estimated to be up to 8, maybe some studies says up to 15% among patients with myocardial infarction. It affects mostly women than men, and usually has a presentation as a non-STEMI than STEMI. The atherosclerotic plaque disruption is the mechanism that could lead in type 1 myocardial infarction. However, coronary spasm and spontaneous coronary dissection could be possible causes. And don't forget that also in the era of COVID-19, we can have patients with acute coronary syndromes. Here, it was a patient, 55 years old, male with risk factors that he had a prior history of COVID-19 infection. He presented with chest pain, ECG changes, and troponin elevation. His PCR was negative, so the cardiologist proceeded with a coronarography that showed only mild LAD stenosis, once again with cardiac MRI, quite preserved injection fraction. We see the edema in the lateral wall also measured with T2 mapping and native T1 mapping, and that was the case with myocarditis and this subepicardial and patchy enhancement in the lateral wall. Closing my presentation, and I would like to sincerely thank you. Maybe cardiac MRI could be the one-stop shop imaging technique for coronary artery disease, not only, and in order to differentiate from other acute situations. Thank you very much.
Thank you, Dr. Kalifatidis, for this thorough presentation that gives me personally a lot of answers in some questions that I had concerning the use of CMR in detection of coronary artery disease. We have some questions from the audience related to the presentation. So, the first one says, does breath movement interfere with the stress MRI protocols?
As I explained, a very good question. As I explained in the first part, when we see the contrast in coming to the right ventricle, we are asking to the patient to have a breath hold. In order to have the first pass perfusion with keeping his breath, and afterwards, during the second pass, we are asking to have a normal breathing. I saw that we have also additional algorithms with movement correction. So, of course, if the patient is not in a good collaboration or in an unstable situation, of course, it is difficult to proceed with stress techniques. The breathing can affect the final result and diagnosis. But we have algorithms and techniques in order to reduce this problem. And also, for example, if we want to see the global function or the segmental function, we can use, in addition, real-time cine sequences, which are free breathing, and we have a good overview of the heart function.
Yeah, correct. I fully agree with you. And the second one is about, it says, does stress MRI could be performed in patients with advanced cardiac failure?
Actually, if we have a very low injection fraction, it is preferable to avoid the stress situation. And of course, if we have a very acute infarction, it is important to have a stable patient in order to proceed with this approach. I don't know if Ilias have something to add about this. Okay. I think that it is a common opinion.
Exactly. I also agree with you. And the last one, I think, is a general question concerning mostly the clinical part. And says, which is the best preference of clinical cardiologists, the non-invasive or invasive approach for detection of coronary artery disease?
I think that this has been answered before. It depends on the clinical scenario, on the pre-test probability, the age, the symptoms. So Stratos showed before that according to the guidelines, when we have younger patients with lower or moderate probability for coronary artery disease, we can proceed with cardiac CT. As we have a more advanced stage and the probability and a higher age, we can proceed with stress perfusion techniques, stress imaging techniques. But if the clinical symptoms and all the signs are very indicative for coronary artery disease, we are proceeding with coronarography. I think this is the general point. It has to do with the pre-test probability, and we have to choose the safest and the test that will give us. If we can have an answer with only one test, that will be preferable in order to get to Ithaca faster. Thank you very much.
So I think now we can proceed to the next part of the second session with the interesting cases and the voting system. Once again, thank you, Dr. Kalifatidis, for the answers on these questions from the web audience. So if there is also a question from the audience in this room, we have, yeah, please, use the microphone. There is a microphone near you.
Perfect.
Is there any specific site that is more probable to produce artifacts?
Sorry, could you repeat the question?
Is there any specific site that is probable to produce artifacts during a good examination?
Of course, yes, very good question. Arrhythmia could be a source of a lot of artifacts, especially severe arrhythmia. If it's mild, of course, there are arrhythmia rejection techniques from the scanner. We can use the triggering, and we can improve our image quality, so our diagnostic confidence. But if we have severe arrhythmia or tachycardia, or if the patient cannot collaborate with his breath hold, then we can have artifacts that could affect our diagnosis. Also, if we have devices, for example, not usually in pacemakers, but in ICDs, we can have that are compatible with MRI, and we proceed with CMR examination. We can have artifacts from this, the parts of ICD, but also there we can have some additional tricks from, for example, we can have the patient with his hand like this, so we can leave our field of view with less artifacts. Other artifacts could be a wrong positioning of our slices, as I showed before, folding artifacts. I don't know if I have covered your question or you are thinking something more.
I mean specific parts of the heart that can produce easily.
Artifacts in normal hearts.
When you perform
Mm-hmm.
but there's some parts that can produce artifacts.
Like?
You had a slide before.
Mm-hmm.
Please use the microphone in order to hear you.
No, please proceed with the microphone.
If there are any parts in the heart that can produce, for example, in some parts of the myocardium, in some special places that have higher chance to produce artifact. Like you had a slide before that showed an artifact.
The
And
folding artifact or not?
yeah, during perfusion.
Yes, during perfusion. Perfusion, the dark cream artifact.
Yeah, the dark
the
cream.
dark cream. Okay, the dark cream artifact. It can happen. It can happen. As I mentioned before, some characteristic features of the true perfusion defect and the dark cream artifact. Usually, it is very thin, 1 pixel size. The dark cream artifact. You can see it also in stress and rest. From the other hand, with a true perfusion defect, it is much wider. It could be subendocardial or transmural, and you can see it only in stress and in coronary territory. So with it needs experience as much as more examination you see. You are more familiar with this artifact, and you can discriminate and say, okay, this is dark rim artifact and not a true perfusion defect. Mm-hmm.
Thank you. And one question from my side. According to your experience, which equipment is the best for CMR, the 1.5 Tesla or 3 Tesla? Of course, I think you prefer the 3 Tesla, but what's the preference, and which of these two, let's say, options is the best?
On the contrary, for the clinical practice, I prefer 1.5 because it's much more stable. The magnetic, the heart is an organ that it is moving, so we have to deal with all this movement and artifacts that we could have from higher field of use, higher magnetic fields like 3 Tesla. The advantage in 3 Tesla is the perfusion sequence. It could be much, not much better, it could be better, but for the clinical assessment, it doesn't add any significant improvement for the diagnosis. One tip is that in 3 Tesla, maybe we can use much more easily the gradient echo sequence and not the SSFP that we are widely used now in 1.5. And this is in order to avoid the artifacts from SSFP. We have to proceed with seaming, etc., etc. And usually for 3 Tesla, the most appropriate sequence is gradient echo.
Okay, thank you, Dr. Kalifatidis. So I think we have to go to the next part with the cases. Let's have some fun with the cases.
Yes, this is the fun part. I would like not to be from you to ask, not to be shy and vote for the cases, have questions, discussion, and I would like to ask Kostas, would you like to start with the cases? Dr. Konstantinos Michailidis, consultant cardiac radiologist from Kozani. Now he will present us nice cases, and we are really excited and wait to see the quiz.
Okay, let's start. I will try to go all through. There are 3 cases, kind of, but I will try to go like there are 4 cases, but the 2 are the same, kind of. So let's start. It's a 42-year-old female with no risk factors that presented with paroxysmal arterial hypertension. It's really interesting the fact that the cardiologist who admitted this patient is here with us today. So Dr. Lapropoulos is this patient and leaded the treatment plan for her. So she presented with arterial hypertension, a very young lady with no risk factors, and she had some atypical ischemia-related rest ECG changes. Troponin was negative and echo was normal. So here you could see the electrocardiographic changes to demonstrate you, as Stelios demonstrated on this ECG. We have a mild ST depression on the lead 6 and 3. Anyway, I cannot see very clearly, but anyway, the patient was discharged from the clinic with the diagnosis of some paroxysmal arterial hypertension with some ECG changes. And at this point, I would like to have the first question. What is the most appropriate test? Okay. So, for a 42-year-old lady that has no risk factors and her symptom is arterial hypertension with mild ECG changes, what do you think is the next step in diagnosis? Stress echo, CTCA, coronary artery calcium score, renal ultrasound, scintigraphy? According to all this, this is, okay, most people saw it for CTCA. I personally think it's renal ultrasound. According to guidelines, the patient has to be reassured that there is nothing significant going on with her. Okay, atypical ECG changes in such young people, they're rarely suspicious. And although, okay, we have hypertension, and hypertension that does not respond to a lot of drugs. So it's resistive hypertension, and we'll have to check for renovascular and other causes. So looking again at this figure that Stratos showed us on, can we proceed with the presentation? The team that says low risk, and low risk people need reassurance mostly. Of course, as I told you before, that Stratos showed too, that she had this atypical ECD, ST changes, ST segment changes, but I did an echo ultrasound on her, vascular ultrasound, and renal arteries are unremarkable. So I get a phone call from my friend and cardiologist, Elios, and he tells me, we're going to do a cardiac CT. I said, okay, we'll do a CT angio, with CT a calcium score. If calcium score is 0, we can stop, because she's not typical symptoms, so it's a good idea to stop. And if I suggested that we proceed with this scan further, trying to check what is happening to the adrenals. So although it was a calcium scoring scan, this one, it was negative. Calcium score of 0. What do you do next? Do you proceed? So I called my friend cardiologist. I'm like, should I stop here? Calcium score is 0. It's a good idea to stop. He's like, no, proceed. So I said, okay, I'm going to proceed with the imaging, but I'm going to go all the way down to the upper abdomen and try to get some images of play. Not one play. I'm gonna proceed with some images. No, it doesn't want to play. With some images of the adrenals. And if you can see down here, there is an adrenal nodule on the right adrenal. So we have a finding to account for the hypertension. But Stelios told me to do a CT angiography too, and unfortunately I saw this. You see, that's a very bad quality. I tried to do it very low dose. I reached the adrenals, heart adrenals, with 100 DLP, nothing. But calcium score was 0, pretest probability was low, and then I see this. And you're like, okay, now what do I do? So the patient was correctly referred by the cardiologist for interventional procedure. Unfortunately, in the first effort, they could not cannulate because the patient was in such a stress. They could not cannulate the left main stem artery. So the quality of the images that they acquired was bad. So what they said is, okay, we think we can see some stenosis that I can show you is it actually corresponds with the stenosis that we were seeing in the, if you can see it here somehow. And then the decision was made to proceed with stress echo. So they were not certain. So we have here with the low energy acquisitions that there is no regional wall motion abnormality. And here with 25 watts of bicyclic effort, there was no change. And then we can see here that in the high effort, 100 watts of loading, the anterior wall is hypokinetic, does not thicken as well as it was doing before. So,
Dr. Michailidis, please use the cursor in order to see. We can see. Okay, thank you.
This one. Okay. So what happened later on? This lady was actually here the stenosis. You can see that they achieved a very good catheterization. Here I made some magnification of the stenosis. So the stenosis was here. You can see that the balloon is ready to be inflated, and then they inflate the balloon, and the stenosis is normal. So it was finally, it was a stenosis. And what do I want to say about this? Okay, it is very rare. We should practice according to guidelines. But when we have a very well-experienced clinician, you have to trust their clinical thinking. And if you trust them, you can proceed with what they want. Otherwise, I mean, okay, guidelines are good for most of the patients. It does not include everything. But on the other hand, of course, you do not want to scan every 40-year-old lady without any risk factors because of hypertension. Okay. Second case. So I'm going to show you two different cases. There are two cases that I have with follow-ups. They had a CTCA 12 years ago, then they received another CTCA later. But the two patients did a different life in between. So we have here a 25-year-old male, which is asymptomatic. He's a smoker. He has dyslipidemia. He receives statin for a lot of years, and he's a typical type A personality. He had coronary CT angiographies 2008 and 13. He takes his medication regularly. He takes statin and aspirin, but he did not quit smoking. And he's generally, his personality is quite dangerous. So he comes back for a third scan in 2020. I'm going to show you, I think it's quite interesting to see the quality of the image, how the quality of the image changes through the years, and how the doses decrease through the years. So in 2018, he received about 1,500 DLP of radiation. In 2013, 580. In 2020, 315. If it was 2020, now if you would do it again, it would be half of this. So radiation doses decrease for this patient. Calcium score that was 413 in 2013 was 958 in 2019 to 2020. So calcium score increased. Okay. What is the next? So please, the next question. What do you think we should do with this patient? He's asymptomatic again, but he wants his referred wants there is no stress test finding, nothing else. He's an asymptomatic that he tries to check because he does not behave with treatment and smoking, basically, with prevention. So what do you think we should do for him? Should we do nothing? CTCA, SPECT, stress echo, or interventional coronary angiography? So it is a patient that is 55 years old. We know that he has coronary artery disease. We knew it from his previous scans. He was detected with coronary artery disease in 2008, non-stenotic, non-significant, and 2020. What do you do next? What do you think is important?
I would proceed with stress MRI. But
yes,
I don't see it as an option.
I forgot it, because if I had it, it would beat everything. Then there would not be anything else there. It's the one-stop shop, probably.
Three, 2, 1. Let's see the answer.
And what is the correct answer? The correct answer,
I think that the audience is mixed.
None. I mean, you have to realize, okay, it's not so clear, straightforward cases, not the typical straightforward where you apply guidelines. But what we know is when we have somebody that has known coronary artery disease, coronary CT angiography is not important. And you have then all these stress methods that do not offer anything just because the patient is asymptomatic. It would be a good idea to perform stress SPECT or stress echo if he was symptomatic. And interventional coronary angiography, again, if there was either symptom but anatomy from is as limited value as this one. And the answer, what would be appropriate for him? Stress ECG is an excellent study to assess the performance status. It was not included here. I just purposely want to show you that none of this is enough. It's not the advanced imaging that will give a good follow-up for this patient. Stress ECG. The normal ECG stress test for the asymptomatic is the ideal way to follow them up. Okay. But we have this statement here from the guidelines. It might be appropriate to perform CTCA in selected asymptomatic high-risk people, especially for those that have a higher likelihood of large amount of non-calcified plaque. But this is not the situation. Here, this gentleman, he had known coronary artery disease. Guidelines like, or ideas like this does not apply this situation because we know that he had coronary artery disease. And this is a very good statement that it's really appropriate to perform CTA in low or intermediate risk asymptomatic subjects. Generally, CT coronary angiography is useful for people that have a typical chest pain or some kind of heart-related symptom. So I will show you here how images change through the years. 2008, you could see this very nice LAD, good quality images, and you can see that there is a plaque in the middle AD that is not important. In 2013, you can see that there was a decrease in radiation, but there is a lot of noise in the background. I performed this study with a 64-slice scanner, these 32-slice scanners. And then this is the last study from 2019. And you could see that how this plaque evolved. It is very calcified at this point, but again, the lumen remains mildly affected. The calcium has increased a lot, and you can see calcium also in the origin of the first diagonal. These plaques do not have potential to harm the lumen, these nice oval-shaped plaques. Again, you can see here the LAD, how it changed in the years. Here has a lot of contrast. So again, so this is 2008, 2013, 2020. And here we can see the circumflex artery, 2008, very nice images, noisy images, but good resolution, very decreased radiation though. And we can see here that circumflex is quite well. And here we can see the obtuse marginal one, which is again a very nice vessel. What happened to the OM2? In 2009, he had this plaque that is a quite unstable plaque, which seemed to stabilize in 2013. It's mostly calcified. In 2020, it was occluded. He had some short segment chronic total occlusion of the second obtuse marginal branch, which was quite large, although the patient was in statin treatment but never quitted smoking. So, question again, please. What should be the next imaging choice for this person that we found some occlusion? He's asymptomatic, has 2 centimeter long chronic total occlusion in the obtuse marginal branch. Is it nothing? Is it stress MRI? Is it SPECT, stress echo, or interventional coronary angiography?
Should we proceed? Okay. Yeah.
Okay.
Correct one.
The answer is the fifth, interventional coronary angiography. That means that for CADRAD 5, the suggestion is that you perform interventional coronary angiography and or viability assessment. Of course, you can, stress echo would be an option to this, to perform viability. Of course, MRI is an option to this, but if we take it as a stress for to check for ischemia, it's not useful in this case. As CADRAD 5, they need, even though I think this is going to change. With the knowledge of the ischemia trial, I think this will go to performing dynamic method to see if there is ischemia. Anatomy will not be a very good idea in this situation, I think, in the future. But according to CADRADs, they need interventional coronary angiography and viability, maybe, and or viability. Okay. On the other hand, we have another case with somebody that had follow-up studies, that he had one study, so proceeding with the same case, the different scenario. He's a 56-year-old male, asymptomatic, with family history in dyslipidemia. He used to smoke in 2008, but he quitted it as soon as he received the report from his first study. He's a medical doctor. He had CTCA 2008. He takes his medication very regularly. He achieves very good targets on LDL cholesterol. And of course, he also receives statin aspirin, but he quitted smoking. His calcium score in 2008 was 8. in 2020 was 300 times more, or 200, or I don't know how many times more, 576. So according to calcium score, supposedly, again, his risk stratification is dismal. But we know that this person is 15, 12 years on statins. Statins cause plaque stability and plaque calcification, and this is a good thing to see. It's not an adverse feature. So in 2020, we can see here that we can see here his study. In 2008, he had mild calcifications here, that mildly affected the lumen. Here, the patient has quite thick, bulky calcification along the length of LAD, but there is zero non-calcified plaque. Here it was a partially calcified plaque. Here is a calcified plaque. So it's more stable. And here we can see that in this, I think this obtuse marginal branch is quite stable. And here with the circumflex artery, you could see here a partially calcified plaque that has been calcified. And the right coronary artery has this, again, long segment calcified plaque, but there was nothing here when he performed the study. Not to forget that this patient has really bad family history and really bad dyslipidemia. So, what do we do about this patient? Can we have the next question? So this patient had a second study 12 years later. What happened with his risk stratification? How would you judge this patient before the second study, or what did this study you think changed the second study? Okay, in the first study he quit smoking, he started statins, he did all this. What happened in the second study? What impression would you make? Would you increase risk stratification like it happened with calcium score? Would you decrease risk stratification just because years went by and nothing happened? Or risk stratification is pretty much the same, so the study did not add anything for this patient? So, do you have a...
Very good statement.
Yeah, we have the answers.
Okay. Risk stratification is unaffected. Basically, yes, this happened. Even though most people believe that they decrease the risk stratification, no, risk stratification is unaffected. This patient is very high risk. He has documentation of coronary artery disease, he has dyslipidemia, and he has family history. He's very high risk. No matter what happens in his imaging, his LDL cholesterol target is 55. Okay, so nothing really happened with this disease, and we can see it with the new guidelines, the 2021 prevention guidelines, that down here it is the very high risk population, and it is the population with documented atherosclerotic disease. Do not forget, okay, he's a 55-year-old patient. He's not that old that he's allowed to have so much atherosclerosis, so his risk stratification remains bottom low. Target LDL 55. I think we should proceed with the next one.
Point, could I ask you something?
Of course.
Would you suggest, in order to see this progression, a serial examination with cardiac CT, and if yes, how frequently?
Okay, the statement is clear. When you find something on a CT scan, you should not follow it up. There is nothing to be offered by follow-up. Only curiosity can. The only case that we can perform a follow-up CT scan is if somebody is zero at some point of his life, and then 10 years later, if he has nothing, it's a Cadrat zero study, and 10 years later has a new atypical chest pain with normal ECG findings. Then, okay, yes, you can do a CT coronary angiography, but anatomic methods are not good to follow up anatomy. And of course, it's nice to see how the plaques change, but this is pure curiosity because this thing does not affect treatment. I mean, you will still have to remain with very low targets no matter what you find. So ideally, you should skip study. And in these cases, stress ECG is an excellent method to follow up patients with known coronary artery disease and plaques. It's a very good method to assess, and it's you can be done in a practitioner's office. It is cheap, it's nice, and has a lot of information about how this patient would react on loading, as hypertension, arrhythmias, and very different things. And we should think about this like radiologists every time. I mean, we offer a very nice method. We do low dose studies, low contrast. They're easy, nice, convenient. But first, we have to think what we have to offer clinically to our patient. And curiosity is not a clinical indication.
Okay, thank you so much.
I think I should stop to have you guys proceeding. If I have one more case to show you, but I'm sure there is a lot of MRI and you have very nice things to demonstrate. Do you think I have more time? If you would agree, I have one more case if you want.
Yes,
We have a
we
quick
can proceed,
case,
yeah.
of course. It is very interesting.
Why not?
Okay, these are two family members, two brothers. Okay, one is 43 and the other one is 38. Both of them are asymptomatic, both of them are smokers, and both of them have really, really, really bad family history. Their father died without being a smoker when he was 45. Their sister, who is 38, had a CT coronary angiography because she had a symptom and she had a quite extensive disease. So generally, they have a very bad family history. We start with a calcium score. The first guy has a calcium score of 0. The other guy, the younger guy, has a calcium score of 2. The implication for both of the calcium score of low calcium score 0 or 2 in short term is good. But long term, of course, okay, this looks good, but a 38-year-old person with a calcium score of 0, he's a bomb, long term wise. If he started so early, that means that the plaques are going to progress generally. Okay, and we see the first brother, who is the older one. We can see that the circumflex looks good, the right coronary artery looks good, and he has this plaque here in the proximal LAD. This is a plaque that causes minimal luminal diameter, and he has a remodeling index of 1.6. So it has very big positive remodeling, and it was quite inhomogeneous. On the other hand, the other brother, he had a very nice circumflex again. Actually, this is a dominant circumflex. Here is an obtuse marginal, and this is the circumflex. And he had these partially calcified plaques in the first third of the LAD, in the proximal LAD. Both of them, they cause minimal stenosis, like you can see here. Both brothers have minimal stenosis. What is the difference between these two plaques? Is one of the two more vulnerable than the other? Probably the first one is more vulnerable just because it has inhomogeneity, it has two vulnerable features here who have some spotty calcification. Remodeling index is not as high. Can we see the last question, please? Or the one before the last? Okay, so these two brothers, after these studies, they are asymptomatic, but as we said before, in the guidelines we can do asymptomatic on very high risk people. What do you think their LDL target? Because we have to know that one of the major roles of CTCA and calcium score is we set the LDL targets for our patients. Whenever we have to risk stratify them, and kind of, depending on our stratification, we set the most correct targets for LDL cholesterol. So what do you think is the LDL cholesterol target for both of them after this study? Is it 150, 130, 100, 70, or 55? I have to tell you that total cholesterol, as we know it, has no value, has very minimal value in assessing a patient. It's all the guidelines in cardiology and most of the knowledge is produced about LDL cholesterol, and the guidelines mostly involve LDL cholesterol and the targets, and in a few cases HDL cholesterol or some other biomarkers. Are we ready? Okay, we can see the answers. 70 is 40%, 55 is 30%. Unfortunately, that means I did not convey my messages well. in every single question that I asked, most of the audience was wrong. Probably I make wrong questions, or I did not, because I'm sure that they know more than me. Anyway, the 55 milligram per deciliter is the target. As we will see in the guidelines, of the prevention guidelines, if we can see the next slide, that for people that they have okay, as this algorithm, as it goes from the beginning, and we'll have different risk factors and different findings, so we'll go to the very high risk. So it's because they have very, very high highly increased cardiovascular risk factor with, as I told you before, vulnerable plaque. It's much worse than having a significant stenosis. So you understand that these people, they're at increased risk of having a major adverse cardiovascular event, and in the way to prevent this is stabilizing the plaques, and we'll have to reach an LDL cholesterol level of 55. That makes the plaques, they will make the narrowing, they will decrease the narrowing and will make the plaque stable. This is our goal. And thank you very much. I have no other cases to show you.
Okay, thank you, Dr. Michailidis, for these very interesting cases. For me, it was clear that I had to refresh my knowledge concerning all of this. And it was very important also for, let's say, how to proceed in these clinical situations. So thank you very much. And Dr. Kalifatidis, could we proceed with some more interesting cases in the
yes,
section of
just one comment, and I think that the message, Kostas, from this final case could be that although we have a young patient, asymptomatic, but high risk due to the family history, and with calcium score of 0, we have to proceed to CTA.
Exactly.
Because we saw this impressive plaque,
exactly.
Valuable information that we cannot get with other technique.
Exactly. I have to make this point too, that these two last cases was Cadraj 1V. This is my favorite report to give, because I'm happy to give it to somebody. It's good to know if he is Cadraj 1V, but there is no other technique that can detect a Cadraj 1V. Meaning that it's even having a interventional angio, if it is 10% the stenosis, it is very easily not to be seen, not to be detected because of the nature of the imaging. So, and we know now from the previous talk that these plaques make the prognosis for these patients really bad. So CT offers a lot on them, and on people with very bad family history and people with diabetes mellitus, calcium score a lot of times is not enough. That CTCA gives for this group, the diabetes mellitus group and family history group, I think CTCA has to be done. We cannot rely on calcium score alone. Even a calcium score of 0 doesn't say a lot.
Thank you once again. Thank you for this.
We have one question from Dr. Dakileris.
Real world question. Dr. Michailidis, are you aware of any literature that takes into account for risk classification the psychological stress profile of the patient?
Exactly, you're very right. It's a very important thing. The European Society of Cardiology has risk modifiers. So we have, we do all these cholesterol measurements and glucose, but major anxiety, depression, stress, low socioeconomic status, poor socioeconomic status, and something like recent separation, loss of person. You can easily re-stratify your patient to high risk without having all these characteristics. And depression and bad mood is really something that can cause significant stenosis.
I'm asking this tricky question because I fall on to an article that estimated that psychological stress is an independent factor that accounts for about 50% of coronary artery disease?
I think I totally agree, and I think it does not affect only coronary artery disease. It affects also neoplasms, like all the autoimmune diseases. We have to make a message that really sadness, real sadness, depression, is a disease, it's not a feeling. That you have to treat it, you have to go ahead, you have to fight against it, because eventually you will get sick. It's not only the bad mood, it's real, what melancholy was for the ancient world. Melancholy is a description of black bile. So they knew it from back then that somatization of the bad mood, that our emotions, they can be turned into real disease.
So feel no stress and feel your best. As we said before, this is an important message. And I will fastly proceed with the next cases. Let's see, now this is a case a few years ago. We scanned with Ilias together, a good colleague, 58 years old male, with obesity, smoker, and prior history of bypass graft, that he presented with chest pain during effort with no ECG changes. His echocardiography was normal with normal biomarkers. And so, can we have the next question, and how would you proceed for, with the further exploration for this patient? Would you do a treadmill test? Would you proceed with invasive coronarography, a pharmacologic stress test imaging, or CTA? Actually, when you have to do with colleagues, it is always difficult to convince them to do further examination. For sure, it was he was negative to proceed with coronarography, invasive, and as I showed in the previous presentation, and according to the latest guidelines and recommendations, we can use CMR in the evaluation of chest pain, also in patients with prior CABADs. And of course, we've proceeded with stress perfusion CMR. And here are the SINE sequences in long axis and some representative short axis slices. And as we can see, we have a preserved injection fraction. We have some abnormality in the wall motion, especially here in the apex. We see some probable dyskinesia, but globally we have a preserved injection fraction. Afterwards, I will show you the stress perfusion images in the upper row, and here in the lower row during rest, the rest perfusion. Please check carefully if you see any perfusion defect. I will show you the static images in the upper row during the stress, and here during the rest. And here comes the next question. And do you believe that there is any perfusion defect, and if yes, in which ischemic territory or territories? In LAD, right coronary artery plus circumflex artery, we have a case of with three vessel disease and or left main plus RCA, or we have a disease in LAD plus right coronary artery. Can I proceed?
Yeah.
Okay, I think that the audience is quite mixed, but most of the people have chosen the right answer. And once again, I would like to show you the images here, the static images. We can see this almost, I'm sorry, this almost circumferential perfusion defect, these dark zones here in this slice, in the anterior wall, in the septum, in the anterolateral wall, but here also circumferential almost, and in this case and in the apex, that disappears during the rest perfusion. Of course, this patient referred for further exploration with catheterization, and as you can see from these nice projections, the bypass graft was patent, okay, but we see this severe left main disease also in LAD and circumflex artery. In addition, this is a static image. In addition, we can see the right coronary artery also with severe stenotic lesions, and so this patient further had angioplasty for these severe lesions. So we can see how we can use this technique even in this category of pathology with three-vessel disease. We can nicely see even visually these perfusion deficits. Of course, as I mentioned before, with perfusion quantification, newer strategy, newer technique, we can have numbers and calculations. I don't know if we have in together with us Kostas Kasapidis. I don't know if Kostas, you would like to have a short comment or afterwards about the quantitative perfusion technique. You can have the microphone and talk to us a little bit about this project.
Sure, happy to, Alexandros. So basically, what we try to accomplish here is we try to add the arterial input function in the equation of the perfusion, and in this way we have developed an AI algorithm which has been validated through the NIH with Professor Arai, which shows significant significant, quite high actually, specificity of the quantification of perfusion, which is not inferior to FFR. This is the first publication which came quite positive for this technique. Currently, we can perform the quantitative perfusion using the commercially available perfusion sequences, either the gradient echo or the SSFP. What we need today, we need a dual bolus approach. So we give an AIF bolus. We do the stress mapping, then we give the stress bolus, and then we do the same dual bolus approach for AIF and stress to acquire our rest images. But pretty soon we will have FDA approved dual sequences. I'm quite positive this will be still in 2022, where we will actually combine in the same sequence the AIF and the myocardial perfusion series. So we will only need a bolus for the stress and the bolus for the rest, and at the same time we will be able to get the full quantitative, the full quantification of the stress perfusion.
Okay, perfect. So a lot of innovation, and you think, Kostas, that in the next 1, 2 years, 3 years, it will be much more globally available, this technique? How do you see the progression?
I think our experience showed that, for example, with the pre-bolus or the dual bolus approach, it requires some additional efforts to change the clinical protocol in order to adapt into that. But with the dual sequence approach, I strongly believe that this will change. This will be a game changer on the way that we currently diagnose the ischemic heart, for sure.
Thank you so much. You can find much more information in the site of Circle about this project. And just to show you finally from the previous patient the late enhancement sequences, another useful technique, we can see even small infarcted areas here not known till the examination for this patient, and for sure very difficult to see with SPECT these small infarctions. Let's proceed now with the second case, a 44-year male smoker with dyslipidemia. He presented with non-STEMI. There were difficulties to estimate the region of ischemia from ECG, and the patient referred for further exploration with coronarography. And here we can see his coronary angiogram, where we can see stenotic lesions in the right coronary artery, a significant stenosis here in LAD, but also we see an obstruction in the circumflex artery. What was the further management of this patient? Of course, this stenosis in LAD was considered to be the responsible for this event lesion. The patient had a PCI, primary PCI for LAD and right coronary artery, and here we see the excellent result. But what about circumflex artery? The whole image was that circumflex artery was much more probably chronically occluded. But this is another procedure. In order to proceed with CTO, it is a more a procedure that needs much more time, radiation exposure, much more risky for the patient, and it is important to know if this problem, this pathology with circumflex, it is important enough to proceed with CTO. And in order to assess if there is any important ischemia, we proceeded further with stress CMR. Costa showed before that after CTA and the occlusion, of course, invasive angiography was needed in order to see the coronary arteries. Here we have the invasive angiography, but we want to know if the occlusion of circumflex artery is relevant, and we have an important ischemia. Here are the first images with CMR in 3-chamber and 4-chamber views, also in short axis slices. We can see that we have a preserved injection fraction. We see some abnormal wall motion here in the posterolateral wall. We proceeded further with stress and rest perfusion images. In the upper row, it is you can see the stress, and in the lower row, the rest perfusion images. And here comes the next question. Is there any inducible ischemia in this case? It's simple, yes or no. You have 50% in order to be correct. If you would like to see once again the images. Okay. I will wait a little bit for the answer. Yes or no, we have ischemia here. And the right answer is yes, of course, almost 100%, 90%, very nice. And from the late GAD images, I described before that you always have to display the stress, the rest, and the late enhancement images. If I will show you again, the area with ischemia is the anterolateral segment here in the base, the mid, and in the apex. So we have more than 2 segments with perfusion defects, ischemia. We have an important ischemia in this patient. In combination with late GAD, we don't see any infarction here, but surprisingly, we see a small infarction here in the posterolateral wall, in the area with the affected wall motion, and probably this was an old infarction, not known for this patient, a silent infarction, and also we are assessing in the same time ischemia and viability. Once again, the correlation with the stress perfusion images, we see the perfusion defect with no enhancement. On the other hand, we see the infarction here in this area. I'm sorry. And so this patient proceeds further for CTO, and we can see the nice result for the opening of the circumflex artery. And just to show you from the literature that the importance of CMR prior CTO, another clinical case here with occluded LAD, we can see the perfusion defects during stress and post-PCI, the disappearance of the perfusion defects. Another clinical case here with occlusion of the right coronary arteries. And from this publication, we can see that we have an improvement in the volumes and the injection fraction of the left ventricle in comparison with the pre-CTO and pre-PCI procedure. And also we can see that there was an improvement in the myocardial perfusion reserve before and after revascularization, not only in the CTO territory, but also in the remote coronary artery territories. So, no radiation, very useful stress perfusion imaging technique with CMR combination, perfusion defects and viability, and very useful tool also in this case prior CTO. I don't know how we are with time, Thanos. I can show another clinical case.
Yes, we can show one more short case.
Okay. Maybe just one final case. It will not be with stress perfusion, but 43 years old male that presented with chest pain, troponin elevation, abnormal ECG, and his coronarography was completely normal. Once again, CMR in order to make the diagnosis for this pathology, this acute event. And from these slices, long axis views, check carefully. And here comes the next question. From these SSFP sequences, do you believe that we have a normal, global, and regional function? We have a normal global function with segmental dysfunction. We have a reduced global function with segmental dysfunction due to ischemic heart disease, or reduced global function with segmented dysfunction due to non-ischemic heart disease. And the right answer is C. Okay, very good. I think that most of you answered correct. And that was a case with a slightly impaired global function. We see the segmental dysfunction mostly here in the apical part. You can see nicely also in this projection in 3-chamber view and 4-chamber view, associated with edema in this area, affected area, and we can see with late enhancement, with mapping and after with late enhancement, this ischemic pattern of enhancement affecting also the subendocardial layer, and that was a case of Minoka. So I will finish with this case. I don't know if there are any questions. Otherwise, Ilias can proceed further with the final cases.
Yeah, thank you very much, Dr. Kalifatidis. Let's proceed with the rest of the cases, and finally we can have a discussion using the question panel.
So, the first case is a 67-year-old male with angina. He had arterial hypertension, dyslipidemia, and was a smoker. Was referred for coronary angiography, and he had no previous cardiac intervention. That's his coronary angiography. The right coronary artery is blocked, and we see he has 80 or 90% stenosis the first marginal, and also intermediate stenosis of the LAD. And the question, Melina, is now, what should we do? Should we perform a bypass surgery because he has a 3-vessel disease? Should we treat conservatively? Okay, thank you. And we see the CNM first with a good ejection fraction and the stress MRI. And here we have the static images compared to the late enhancement images of the left ventricle. And back. So, the questions, please. How should we go further with him? Should we perform CABG because it is a 3-vessel disease? Should we treat conservatively because there is no viability in the inferior wall? Should we perform a PCI of the right coronary artery and the marginal because he is symptomatic and he has more extended ischemia than the scars? Or just conservatively because the induced ischemia is not extended? Again, is either PCI of the right and the marginal asked bypass surgery because it's a 3-vessel disease, or conservative treatment, but because of a no viability of the inferior wall, or because of a very small amount of induced ischemia. Okay.
So we have the answers.
Yes, fantastic. And get back. We see that we should perform a PCI of the marginal and the right because the patient is symptomatic and the extent of the ischemia is more than his scars. Let's go to the second case. A 75-year-old female with diabetes and ex-smoker, dyspnea, and the primary decision was for a coronary, or for a CT coronary angiography. And we had these extended calcifications with Mrs. Aglavara, Dora. And the main problem was the stenosis in the right coronary artery. Then we performed a stress MRI, and we see a good preserved ejection fraction, some aortic stenosis, but not that severe. And the stress MRI she was breathing and moving, but those are the images. Thank you. And the late enhancement. Again, so the questions, please, Melina. So, what's true? This patient had first to receive a coronary angiography, an invasive coronary angiography, then a stress MRI, and then a PCI. Or conservative treatment is the best option, there is no viability. Or PCI of the right is the best option, there is viability, and there is induced ischemia of the inferior wall, or there is no ischemia, it is a dark rim artifact. The question is, should we have done first a coronary angiography? It's an elder person, diabetic, with a high pretest likelihood to have coronary artery disease, and then stress MRI, and then finally a PCI, or treat conservative because there was no viability, PCI of the right because there is viability and ischemia, or no ischemia, just a dark rim artifact. Okay. I think I have the right questions, Alex. PCI of the right.
I think that the audience is fantastic, and the answers are the ideal.
Yes. There is viability and induced ischemia of the inferior wall. Of course, that's a question why we performed first coronary, CT coronary angiography, but it was not our decision. The physician decided also to take a look at the lungs because she was an ex-smoker, and the lady was not so fanatic for invasive angiography. But of course, another good option would be a stress MRI. And PCI of the right. And the third case, 80 years old male with hypertension and exertional dyspnea and pain. Again, the right coronary artery is blocked, and we have also a LAD stenosis, and we see the retrograde filling of the right coronary artery, as you can see. We performed a stress MRI. We see some hypertrophy also of the septum, but a preserved ejection fraction. Oh, sorry.
Please vote. It's very interesting, this case. And I want to mention that all of these cases are real cases
Yes.
from the hospitals, from Dr. Ninios Hospital, Dr. Kalifatidis Hospital, and Dr. Theophilogiannakos and Dr. Michailidis are real cases.
Yes. We compare also the late yes. The previous. Thank you. We compare the late enhancement images. We see there is no scar or just a little subendocardial scar. And now the questions. What is the main problem of the patient? Is a proximal LAD stenosis because it's prognostically important? Is the CTO, the chronic total occlusion of the right coronary artery because it causes an ischemia? Or he has no problem at all because the right coronary artery gets a retrograde perfusion from the left coronary artery? Or hypertension is his main problem because he has a left ventricular hypertrophy, and that's the reason for the dyspnea. So, the CTO of the right coronary artery because it causes ischemia. That's, again, the right answer. We see that there is an induced ischemia in the inferior and inferoseptal wall, and there is no perfusion defect affecting the anterior wall. It means even if we visually have the have the opinion that the LAD stenosis is 70 or 80%, it does not cause any ischemia of the anterior wall. That's it for me.
Very good.
Thank you very much.
Elias.
Thank you, Dr. Ninios. Thank you very much. Please come to our panel, and we have the last part, a very interesting part, with all of the panel to give us some points, some take-home messages. So, the microphone is yours. You can start.
Okay, let me start. And first of all, I'd like to thank all of you, all the participants here in this nice place, but also through the web for your active participation. And once again, to congratulate GE Healthcare, and many thanks to all the people and to Dr. Athanasios Natsios for the initiative. I think that we had the opportunity to familiarize with these new, quite modern, I would say, techniques. There is a lot of technological improvement, development, new sequences, new scanners, very low radiation, multiple information in order to assess coronary artery disease, who is always a very current topic. I think that from my side, of course I talked much more about CMR. I think that we have seen also through the very didactic clinical cases the importance and the role of CMR. All in one, we can assess perfusion defects, we can see viability, the function, hypertrophy, thinning, and maybe in the near future also the coronary arteries. Once again, I would like to thank you all, and I think that the message is to learn how we can use all these techniques in our daily clinical practice in the best way for our patients.
Thank you very much again for the kind invitation to participate in this interesting meeting. My conclusion is about the fact that ischemic heart disease is not a uniform disease. So it's very important the clinical setting of acute coronary syndromes or of chronic coronary syndromes. Stable coronary artery disease is a very different approach in one or in the other case. And I think that this is something that we must know, all the doctors, not only the cardiologists.
Thank you, Dr. Theophilou-Giannakos. Please, Dr. Michailidis.
Thanks again, everybody, for being here, and thank people from watching from distance. It was very nice to be here and share our knowledge and experiences. And it's a very nice panel with mixed specialties. So, excuse me. The first thing I would like to say is that, okay, I will focus mostly on cardiac CT. It's a very easy and nice study and safe. Make teams with strong participations, and the team has to be clinical, meaning the radiologist and the cardiologist in all this effort. Of course, the radiographers, the nurses, and the whole department, the secretaries, they have to know their role to practice and do the method well. So generally, one person cannot do it all. We need a lot of people. The second thing I want to tell that concerning cardiac CT again, of course, heart rate is the cornerstone of this whole process. So the people who perform it, the method, they have to know how to control the heart rate safely for the patient and be able to overcome any kind of mishaps, difficult situation. So in this case, it is very important. And the third thing is something that is, I mean, it says it by itself, like practice ALARA. We have to, all of us radiologists, to know all the concepts, the ALARA concept as low as possible, reasonably achievable, meaning that radiation is not such a bad thing, but excessive and wasted radiation is a problem. We have to utilize as much radiation needed to answer our clinical problem and not just to make beautiful images. And because the method is here to stay and to give a lot, and it's going to be applied to a lot of people, it has to be low dose. We have to practice the dose, the method like this. Thank you very much, and it was very nice.
From my side, thank you very much for the nice meeting. I think stress MRI is a fantastic one-stop shop. Some people would say it's too expensive, but I think there are a lot of costs of unneeded bypass surgeries, expensive CTOs of the coronary arteries, and so on, and of course a lot of exposure, radiation exposures and contrast exposure that we can avoid with the use of stress MRI. And in the modern area of complex interventions, it's very important to assess first the viability and the ischemia before proceeding to complex cardiac and coronary interventions.
Thank you all. From my part, I want to thank you, each one and all, for your commitment and your not only presentation, but only your discussion, your spirit to this type of image acquisition and image modalities, and the tips that you gave to the audience, not the in-person audience, but also to the web audience. So thank you once again, and all the presentation will be available on demand for the next 3 months in our site. Thank you, and have a nice rest of the day, let's say. Rest of the night.